Okay, so I don't agree. I don't think the CT weight bearing is the all and end all, and I don't think it's going to revolutionize things. I think it's going to be fantastic for giving us alignment answers. I think that the role for that is going to help us see where the foot is and where we should put it. But is it going to give us a diagnosis every time? I think it's going to be somewhat isolated to alignment. I'm going to show you a few cases here, and you're going to have to show me how the weight-bearing CT scan is going to help us make a diagnosis. My biggest problem with my patients when I see 20 in the office every day is diagnosis. Once I make the diagnosis, then I'm just a technician, and we're all pretty good technicians. You got to make the diagnosis. That's the most important part of making someone better. I'm conflicted a bit here because Philips, when we bought our CT-SPECT about 10 years ago, gave us a grant to do the research I'm going to show you. That was part of our deal for the hospital to buy the thing. So we all agree that if you're going to look at soft tissues, we're going to use ultrasound or MRI problems. Bony, we know the value of plain x-rays. We've been using them forever. CTs are great because they give us a more detailed, bone scans are helpful as well because they can localize where the problem is if it's a bony problem. Remember, we're talking about bony problems with CT-SPECT. And CT scans are cool because they give us a great picture of the anatomy. And probably CT weight-bearing scans are even cooler because they show us how the anatomy should be lined up. But a CT-SPECT makes my life easy. It says, here's the problem. Here's the bony problem in this patient. It's for simple people like myself. This has been going on now for almost 20 years, but really in practice for 10 to 15 years. The radiation from a CT-SPECT is lower by a factor of 5 times than a normal CT scan. And the ability to co-register the CT and SPECT portions within 3 millimeters. So you're going to be pretty good for your diagnosis. They're using it everywhere in orthopedics. They're using it to give precise diagnosis of bony problems, precise active bony problems. Here's a case. Okay, so look at this x-ray. Okay, can anyone see some problems here? This patient comes in and does like they all do. They point to their midfoot on the dorsum of their foot and they go, I got pain here. I can see at least three causes for the pain here. I can see TN arthritis, I can see subtalar arthritis, and I can see ankle arthritis. How is the weight-bearing CT going to tell me which pathology to operate on? All right, well, let's try a CT-SPECT. Let's try to get specific. Is it everything? Do we got to do it all? Okay, so there's the CT. Oh boy, I'm still not convinced I know what I'm doing here. We got bad TN arthritis. We definitely have ankle arthritis. Oh, bone scan's looking a little helpful. Look, it looks more like the midfoot. Look at the CT-SPECT. Glad we didn't operate on the ankle because there might have been some malalignment. This person has isolated pathology, bony pathology in the talonavicular joint, so that person gets a TN fusion from me. It got me right to where it needed to go. Another case. Here's another one. Boy, there's a few things going on here. Do you see the fibular non-union? Do you see the OCD? Do you see the os trigonum? What are you going to operate on here? How is this standing CT scan going to show me what to operate on here? How is that going to help my diagnosis? Let's try a CT scan. CT scan. Oh, well, hey, I got pathology. Now I know precisely where the pathology is and what it is. I still don't know what to operate on. Patients aren't helping because they're like, it hurts everywhere. You know, it hurts here, runs up there, it goes over there, and I have no idea what they're talking about. I need precision to make this patient better. Well, look at this. It's a pretty quiet OCD. I would have sworn the OCD was something. It was the fibular non-union. And they did point to that area. They pointed to that area and the posterior medial aspect of their ankle. CT-SPECT told me what I need to do. Another example. I'm going to skip these 3 examples so I can get to the research I'm going to do. I could go on with all these. Here's an example of a os navicularis. I've had coalitions and OCDs. The CT-SPECT keeps telling me what the problem is, which one I should operate on. I could go on forever about this. Okay, we talked about fusion versus replacement. And we all know that when you get periarticular arthritis, probably a replacement's a good thing. I wanted to do CT-SPECT scans on my ankle fusions because I wanted to see if those other joints got active, if the talonavicular and the subtalar joint got active after my CT-SPECT scan. So here's my population. It's only 30 patients. These are expensive to do, and Philips is only so generous with their original donation, but we're going to go on from this. what we did was a CT-SPECT scan before they got their ankle fusion, and we did one at 6 months. That was wrong. We should have done it at a year. Would have been better to do it a year. The study results here, basically what we saw was the CT-SPECT scan showed increased activity at 6 months at the talonavicular joint and the subtalar joint. So this periarticular arthritis things that we all preach about may be true, okay? It didn't show decreased activity at the ankle joint after the fusion because 6 months was too early. Conclusion, fusion is going to start your wear in those other joints. That's where I'm going with CT-SPECT, and that's where I'm going to continue to go. Thank you very much for your attention.
Okay. So